Government's new plan then to tackle COVID-19 could force delays to non-urgent care. To what extent will the NHS be able to cope as it's currently configured? Let's talk to Dr Yaso Browne from the Doctors Association. Dr Browne, welcome to you. Our political editor put it to the Prime Minister that there could be anything up to 3 million hospital admissions. Can the NHS cope?
I think that I understand why there's a lot of speculation about the worst case scenario, and that's important in terms of, thinking about preparation. But I think it's also important for people to bear in mind with this virus that, we as citizens, as well as those that are in the healthcare, are reassured by the fact that 80% of those that will actually get the virus will have mild symptoms and should make a recovery. It usually takes about 3 weeks if it's mild. So I think that's the most important thing. It's common knowledge that the NHS is stressed and is under pressure without the advent of a potential COVID pandemic. But as we're seeing with the announcement today by the Prime Minister, there are going to be plans to almost change the landscape as we know it in order to try and prepare for that. And we've got to believe that it will happen in order to protect the vulnerable. And yes, there is going to be things that need to change and more things that need to be supplied, for example, like protective wear for healthcare workers or more beds or increased people on the ground to help. So there are going to be things that need to happen, which is why we're being told about it, so that we are prepared, but also so that we engage with the mainstay, which is trying to self-isolate if we think that we are contaminated, or to just maintain really good, sensible hygiene, which we should be doing whenever we have minor illnesses anyway.
Yeah, and as the Prime Minister reminded the media who were present in the room that we have a responsibility to make sure we calibrate the sense of risk.
Yeah.
And want of risk at times. On the point that we've heard about contingency planning to encourage perhaps retired health professionals, if needs must, to get involved, to what extent does the care of people with significant respiratory conditions, is that something that's relatively timeless? If you were trained in the 1950s, might most of the lessons that you learned then still be applicable, or does our advances in healthcare running along so quickly that actually the retired doctors and nurses do have a shelf life, as it were?
I think that the individual clinician will only do as much as they are competent to do. I definitely do trust that. So I don't think that someone that has had no ITU experience is suddenly going to try to be an ITU physician. And certainly I don't think that would be allowed either. So people will be operating with their limits and just be there to help as they can. That's the way I would foresee it if it did happen, people were mobilised.
Not so very long ago, the NHS had about 300,000 beds. The number is now around about half of that number, and obviously occupancy is very rapid and there's a sort of flow of people through. Do you take the view that the NHS needs more beds for an emergency, or would that be, I don't know, a little bit like the situation you get at Heathrow, where there's a very bad winter, people say, let's have lots of very expensive snowplows that only get used every 10 years, and people would then complain about the waste of public money. It's a fine balance to strike, isn't it?
It is a fine balance to strike, and we seem to constantly be trying to do that. I think that we already know that in the press, I'm part of the Doctors Association UK, and we have brought it to the press that actually part of the winter crisis contingency plans have been actually almost considering a premature discharge of patients so that you can get the people that are not being able to come into hospital to get in because there is a bed crisis. So that is already happening prior to an advent of this potential stress. And it is a really difficult balance to make. It's a hard job for managers to achieve that balance, and also you're restricted by funding and also the buildings that you have as well. So there's no easy answers or reassurances to give on that, I'm afraid.
Yeah. Are you still practising, Doctor?
Yes, yeah.
What's when you talk to patients who are coming through your door now,
yes,
particularly the elderly, particularly those perhaps with pre-existing respiratory conditions, how would you characterise the prevailing emotion there? Is misgivings, obviously, anxiety, panic, the full spectrum?
Well, I actually work in a practice that is dedicated to the homeless. So this is another vulnerable group of patients that actually don't get a lot of thought about. And, you know, how are they going to actually self-isolate? Are they getting the right resources out to them? There's going to be a health literacy issue in terms of public health education. So, you know, that's sort of the aspect that I'm seeing. I do suspect that when you hear about the 1% mortality rate and that over 80 it's 15%, you know, those statistics, if you are in that category, of course you're going to worry. But the advice is that if you've got mild symptoms, you would assume that it's going to be self-limiting, and to do the necessary things to support yourself through that. If you do start becoming more unwell, then you need to seek medical advice. If you're worried that it's COVID related, then you need to call NHS 111 and self-isolate.
Dr. Yaso Browne, really appreciate your time. Thanks a lot.
Okay, thank you, pleasure. Bye.